All right, so we're going to go over some hopefully basics anatomy of infrapopliteal vessels. Going back, God, more than 10 years ago, this was not basic for me, but all right, so I have no disclosures. So I put this on here as a 2010 sort of a categorization of tibial anatomy and anomalies, and not that this is really used clinically, but just for your reference to show some of the variations that are out there. Tibial anomalies are very, very prevalent. About 10% of the patients in the population have a tibial anomaly. And I think it's important, especially when you're dealing with disease and chronic total occlusions, to suspect a tibial anomaly when things aren't maybe going the way you think they should be, or your wire or catheters are not tracking where they should be. So here's some examples just from our lab of different anomalies, the true trifurcation, high takeoffs of either the anterior tibial artery or the posterior tibial artery. And then some examples where you have a perineal artery that is dominant and supplies either the dorsalis pedis, the plantar vessels, or potentially even the entire plantar arch, like the example in the middle. So again, just some more, just for your reference, how the anterior tibial and posterior tibial come down and join typically in the lateral plantar artery, connecting into the dorsalis pedis through a first perforating artery or a deep plantar artery. And then again, just some more reference images for you guys. So taking pictures of the, especially the pedal vessels, I think are very, very important. This goes back to an older paper by Marco Manzi, but this is the technique I use, take an orthogonal oblique view to try to separate the plantar vessels, the medial and lateral plantar vessel, and the lateral plantar artery typically is the more dominant one and is the one that's more inferior on this image, and again connects to the dorsalis pedis. These images, the path of these vessels are very different when you look at it from this view versus a cranial view. You can see in this view, the dorsalis pedis comes down, I don't know if I can point here, but dorsalis pedis comes down and forms almost like a figure 8 as it joins the lateral plantar artery. And so sometimes when you're doing interventions on this, it's very important to shift back and forth because it may look like you're in the right place, but when you shift to the other view, you're in the lateral tarsal artery or something like that, and that happens. So again, just some names of the branches down here in the foot, the perineal branch, the perforating branch, and the lateral calcaneal branch. So some plantar arch variants. So here you see a very super dominant plantar vessel with really no dorsalis pedis. Here you can see absence of the dorsalis pedis, and you have a dominant lateral tarsal artery that connects with a medial plantar artery. And then here, an example of where there is no true connection in the dorsalis pedis and the posterior circulation. So here's an example of the perineal artery coming down and supplying the anterior tibial and posterior tibial circulation of the foot. You can see we put the wire through and balloon both occlusions. And afterwards, you see that you get back the plantar vessels. The distal dorsalis pedis is very small, probably in some spasm here, but you get the point. Knowing these, taking pictures also is very important. So you want to have, obviously DSA, high frame rate, so at least 4 frames per second. You want to stand the pedal for late filling collateral. So here on the right, if you look, you can see the loop filling late right there. So in your mind's eye, this is where the plantar vessel should be running. And sometimes it's putting together pieces of a puzzle. So here is where the plantar arch should be in this foot. Here we, used cart techniques to get through to the contralateral side. And then this is the after result. Also what's important is, we talk about selective angiography, and I'm sure most of you, know from a popliteal standpoint, injection is much better than from up there hooking over the iliac for these kind of cases, but sometimes in the foot especially, you want to get really down into the dorsalis pedis and plantar vessels to selectively inject, through typically an 018 catheter. And sometimes what looks like from a popliteal injection on the left occlusions, when you get into it, you actually have, if you can get blood back slowly, you can inject gently and see the anatomy. And in this case, again, sort of putting together the pieces of the puzzle. Here I had a 014 CXI in the plantar loop there. You can see the 3 markers there. And I injected, and then another injection from above. And again, after we sort of figure out where this arch connects, this plantar arch, this is what we thought from the cranial view. And so here's my wire with a balloon across it, and then again, before and after pictures of that plantar arch now open. So bottom line is, it's important to know these vessels, have suspicion about anomaly, especially when you're dealing with chronic total occlusions, and think about when things aren't going right. I've had patients referred in when they, for like anterior tibial intervention previously with a perforation, and it ended up being a big dominant perineal artery that was fairly simple. That's it. Thank you very much.